Good evening, everyone. We welcome you all to OrthoTV online in association with OREF, Orthopedic Research Education Foundation. And to introduce today's speaker and topic, I hand over to the Secretary of OREF, Dr. Janki Bhadani.
Good evening, everyone. Today we have talus fracture, which will be discussed with our chairman, Dr. John Mukhopadhaya, sir. So, welcome to Orthopedic Research and Education Foundation India again, and I'll hand over to our chairman. Over to you, sir.
Okay, thank you, Janki. And today we are going to talk about talar fractures. This is an area which is not something that is very common and often confusing for most people. I'd like to acknowledge some slides taken from the OTA residence lectures and also the AO trauma faculty sort of support system. And so I think we're going to talk about how we classify talar neck fractures, describe the blood supply and its significance, because this is one of those bones where AVN is not uncommon. You need to see how we plan our surgical approach, and I think this has changed over the years. You need to evaluate what options you have to fix and then also talk a little bit about the complications. So as I said, it's not a very common fracture and overall forms about 2% of all fractures, and it's about 6 to 8% of fractures of the foot. What is important is that it has a high incidence of complications. You can have AVN, non-unions, malunions, and of course, post-traumatic arthritis. The interesting thing about the talus is, unlike many other bones in the body, it is almost 60 to 70% covered with articular cartilage, and it has no muscular attachment. So no muscle is attached to the talus. Of course, you have ligamentous attachments, but no muscles attached to the talus. It also has very complex articulations above with distal tibia and fibula, below with the calcaneum. Again, the facets are quite complicated, and then more anteriorly with the navicular. So it has fairly complex articulations, and also the neck is deviated medially. Okay, so it's not a straight bone like many other bones. Okay. Now, it's important to understand the blood supply, because this is really important in understanding why these problems of avascular necrosis occurs. And the main blood supply is through three vessels: the posterior tibial, the anterior tibial, and the peroneal vessels, which are the vessels which supply the lower leg and foot. Okay, so these are the branches. So you have these anterior tibial artery and the perforating peroneal artery joining to form this artery of the sinus tarsus, the tarsal sinus. And you have the posterior tibial artery, which has a deltoid branch, which goes to the posterior part of the body, and also the artery of the tarsal canal, which is one of the main supplies of the talar body. So the artery of the tarsal canal is important. The artery of the tarsal sinus is important. So these are important because disruptions either through a neck fracture or a dislocation can affect the vascularity of the body of the talus. Now, a lot of these injuries are fall from heights or road traffic accidents. It was interesting that this fracture was coined by Anderson in 1919 as the Aviator's Astragalus, because although it was an uncommon injury, with the advent of warplanes in the First World War, many more of these were seen where the pilot's foot was stuck in the pedal or whatever they had to use for their flying. Okay, so it was known as Aviator's Astragalus. Of course, with modern aircrafts, you don't get this problem. So it's mostly road traffic accidents and falls from heights. And essentially, in most situations, it's a hyperdorsiflexion injury, which then hits it against the front of the tibia. But the forces that go through the neck are mainly shear forces. Okay, so remember, it's the shear forces which cause the fracture and the displacement. And these are pretty significant. And Swanson has calculated that during active motion, almost 1200 newtons of force go through the neck of the talus. And so any fixation you may do should be able to withstand this force to allow permit active movement in the postoperative phase. Now, I think the imaging is also important because it's difficult to get very good X-rays of this fracture. It's important. What we do is we tend to do separate X-rays focused on the ankle and the foot so that we see all the areas of the fracture because some things get obliterated in the AP of the ankle and vice versa. Okay, and the other view that is important is this slight ankle plantar flexion with knee bent with reference to the table of and 15 degrees of pronation, and the X-ray tube is angled 15 degrees from the vertical. This is known as the canale view, and what it does is it separates the calcaneum from the talus, so you can get a clear view of the talus, and this is a useful view. Of course, the CT scans are really the most important tool for assessment of this fracture and for your surgical planning because it can give you details of the displacement, the fracture geometry, the joints, how the articular surfaces are affected, etc. So, and also whether there's comminution, whether there are osteochondral fractures, any debris in the joints. All these are important when you plan the treatment for these fractures. MRI scans are not really something which we use in the acute situation, but is important if you're looking at osteonecrosis or avascular necrosis of the talus post-treatment. Again, because you may use a lot of implants, especially if they are not titanium implants, there will be a lot of artifacts and in its assessment. Now, Hawkins in 1970 is the one who actually reported one of the largest series of these fractures and gave a classification, which was valuable because it was predictive of the avascular necrosis rate, and this was widely used. Okay, so the type 1 is the undisplaced fracture, which even then has a relatively low but still an avascular necrosis rate. So depending on the displacement, but it also depends on whether it's a complete fracture or not. Okay, now this is not common and often missed. Okay, so the two things. One is it's not very common and it can often get missed. The reason is that, as I mentioned, you may not pick it up on regular X-rays, and most talar neck fractures are common and are displaced. And the most common type is the Hawkins type 2, where there's a displaced fracture with dislocation of the body in the subtalar joint. So there's some subluxation or dislocation of the body of the talus from the subtalar joint. It's still within the ankle mortise, but there's some subluxation of the joint. Okay, now here, if the fracture line goes posteriorly into the facets, it is type A. And if it's a little more anterior, where it actually avoids the actual facets of the calcaneum, you would call it a type B, where the subtalar joint per se is intact. Okay, and here the avian rates are between 20 to 50%, depending on which study you look at. And this is, as I said, the most common type. The type 3 is where the entire body of the talus is dislocated. That means it's out from the ankle as well as the subtalar joint. Okay, so it's usually extruded, more commonly laterally, and this is it can be open injuries. It may be closed where the skin is at risk because of pressure of the body of the talus on the skin, and obviously this has very high avian rates. And if it is dislocated and pressing on the skin, this is one of the situations where you need to do an urgent reduction, try closed. If that doesn't work, you may have to go for open reduction. And of course, it has a very high avian rate. And then Canale added a type 4, where apart from the dislocation of the body from the ankle and subtalar joint, you also had a talonavicular subluxation. This is relatively uncommon, but obviously this is a difficult fracture to treat. And you also have many complex talar neck fractures. I think today with the high energy trauma, and I'll go through some cases, the fractures don't fit into any particular pattern, but if they're grossly displaced and the body is dislocated, they would go into the type 4 classification. So what are the emergencies? I think if you have a dislocated closed fracture, if there's an open fracture, closed fracture with soft tissue at risk because of the deformity, and of course, neurovascular compromise, those become urgent. Now, some people would put all talar neck fractures as emergency, but I think studies have shown that this is not really true. And most people, if you looked at it, out of in this survey, out of 109 experts, only about 20 said they would not wait more than 8 hours. Okay, most others felt that it would be more appropriate to do it in the next list where you have all the trained staff available, like a lot of fractures today, which at one time were thought to be middle of the night emergencies. It has been found that it's better to do when you have the proper team and the proper setup to do them rather than rush and do them. Obviously, if it's a fracture where the skin is at risk or it's dislocated, then you need to get the reduction done. You can do the fixation later. Okay. So general emergent reduction of dislocated joint. Also, these patients may have multiple other injuries. So once you've reduced the dislocation, there's no rush to fix the talus. You need to deal with the other more important injuries and then deal with the talus once the patient is fully stabilized. Now, how do you do a closed reduction? Okay, so this is not always easy. Type 2 is not always usually possible. Type 3 and type 4 obviously become more difficult. Okay, so you can do it under adequate sedation. You need to, important thing is to need to flex the knee to relax the gastrocnemius, okay, because if that is tight, it'll become difficult. Okay, then you plantar flex the forefoot to realign the head with the body, do any varus valgus correction, and then you need to pull and directly press on the talar body to try and get in. Okay, you may use a traction pin to get better traction. If that's not possible, you may have to use general anesthesia so that the muscles are adequately relaxed. But don't keep doing repeated attempts at close reduction. If it is not working, then you have to decide, depending on the pressure on the skin, whether you need to do an urgent open reduction. Okay, now, once you've decided that the reduction has been, you need to go ahead and do an open reduction, then it's important to restore the anatomy. And this means align the talar neck, try to avoid any excessive stripping of soft tissue so that you give the maximum chance of revascularization, and start early range of motion. Not early weight bearing, but early range of motion. And the approaches, okay, so if you go back in history, things have changed a bit. Early on, we would just use an anteromedial approach, put a couple of screws on the medial side or wires and combinations. Now, the trend has gone more towards dual approaches. So you do an anterolateral, anteromedial and an anterolateral incision. There are some fractures, undisplaced fractures, or posterior sort of process fractures where you would use a posterolateral approach. If you have a fracture of the malleolus, or if there's a dislocated fragment lying medially, sometimes doing a malleolar osteotomy would help. And similarly, if it's laterally, then sometimes a fibula osteotomy would help. So the medial approach is really between the two tendons, the posterior tibial and the anterior tibial tendon. It's a relatively avascular area without any major blood vessels, and it gives you direct access onto the neck of the talus, the head of the talus, and the navicular. So you usually would try to put the screws through an extra articular part of the distal part of the talus into the body and angulate it in the correct way so that it is at right angles to the fracture in the neck. Okay, so that would be the usual way. and this would be the standard medial approach. Very often today, because in these fractures, the medial side is the compression side and the lateral side is the tension side of the fracture. So if you approach it medially and compress, you may end up in a varus. So either you do not use compression, especially if there's comminution, or you go to the lateral side, fix that with screws or a plate from the lateral side, and then do the medial side fixation. And here the approach is really along one of the borders of the fibula and in the direction of the base of the fourth metatarsal. So really through the area of the sinus tarsi, and that gives you a good approach to the lateral surface of the talus. So this is the standard approach. This is from one of the AO series where it shows you with drawings where your two incisions should be, leaving a reasonable bridge of skin between the two incisions. And then do it with minimal or soft tissue stripping, get down to the fracture, reduce it. And this is where from medial to lateral, you get one. On the lateral side, you would have to put your screws or plate depending on the situation. Today, using a combination of screws and plates is very common. Early on, we just use screws or wires or etc. So in the surgical tactics, consider dual exposures, use an intraoperative distractor. This helps sometimes. Clean up the subtalar joint, leave the deltoid ligament intact. So if you have to go onto the medial side and you need to look into the body area, doing a medial malleolar osteotomy and putting the malleolus down rather than cutting through the deltoid ligament is what is recommended. And if necessary, spad any comminution. You may add external fixators, avoid varus of the talus. Now, reducing the body can be difficult, okay? So even with open reduction, sometimes it's quite difficult. We had one case where the body had actually herniated between the vessel and the posterior tibial tendon on the medial side. And we tried from the approach that we did using a joystick with a medial malleolar osteotomy, we just couldn't get the body back. And finally, we had to make a separate incision and actually deliver it back in the interval between the posterior tibial tendon and the vessels on the medial side, posterior tibial artery. Okay, so as I said, today the recommended thing is to reduce the tension side first, which is on the lateral side. Fix it at the non-articular part. Wherever you have to go through any articular part, you need to countersink the screws into that. So I'll just go through some examples, some relatively difficult, some relatively easy. Now here there's comminution, there's dislocation, but you can see that the talonavicular joint is okay. This is completely dislocated from the ankle as well as the subtalar joint. So it would qualify as a type 3. Okay, and here if you saw that the medial malleolus is also displaced and is also quite badly fractured here. So this patient came to us late, almost 10 days after the injury. So we used the medial malleolar fracture as our approach. Okay, we could get down to this area, we could fix this. This is, like I said, an older case where we just did through the medial approach. Today, we would also probably use a dual approach for this. That was the fixation. You can see the AVN signs here, okay? See that the body is sclerotic compared to the neck. And this in injuries like this, which have remained out for late, is not uncommon. But he did reasonably well. So this is the thing, his follow-up, and this is his follow-up another year later of the implant removal. You can see he's still maintaining a reasonable joint. The slight malunion of the medial malleolus maybe, but did quite well. The Hawkins one, as I said, is sometimes missed. If you look at this fracture, if you look carefully, you can see the fracture line here. And this is really very easy to miss if you're not careful. And this can sometimes show up as an undisplaced fracture, which then later displaces. So that's something you have to be careful of. And here you have an option. These are the fractures where some people would say you can put percutaneous screws from posterolateral to anteromedial because you can put them exactly perpendicular to the fracture and biomechanically they may be more stable. Our practice is still to put screws from anterior to posterior because that's what we've been used to. So here we just used one screw through a mini incision, and we felt that was adequate. He went on to do quite well. As you can see, this is the follow-ups, but this is a relatively simple case and he did well. Now, more difficult cases. Here's a patient who again came to us late. Again, if you look carefully at the x-rays, you can see how the part of the body is out. So part of the body is still in the joint. So it's more like a body fracture than a neck fracture. The neck seems relatively intact. You can see the fracture in the body, the dislocation of the segment of the injury. There you can see how this part is totally, the fractures here, not really in the neck, but through the body, there's also a fracture in this direction. So here we had to do an open reduction, get it reduced. Again, you can see the follow-ups. He did reasonably well here. Here's what we call the Hawkins sign. Look at this. This kind of lucency just below the articular surface. And that is a sign of revascularization. Okay, so that's a good sign when you get this slight area of lucency just below the articular surface. That's a good sign. It means that your body is getting revascularized, and this patient again did quite well. Here, more complicated injury. Again, the x-rays are very difficult to interpret. So you're actually going to need the CTs. I'm not showing you all the pictures, but we'll just show you the 3D areas, which is also could be magnified a bit, but you can see that part of the body is out medially and part of the body is out laterally. And here, so here, if you see, this is the fibula, so this is our lateral approach, and you can see that the area that should articulate with the calcaneum is lying out here. The facet is there. We have to kind of make space for it to reduce it. There you can see the other part of the body there. So you carefully mobilize it, reduce it accurately. It's important to get good accurate reduction. Put your lag screws across, and here, because this is an articular area, you have to countersink these screws. You can see how this screw is being countersunk within the articular area here. They go to the other side, and there are fractures on the other side again, which we had to fix across from medial to lateral. You can see this is the medial side. And after all that, you clean out the subtalar joint, and we also put a distractor. And we also had to put a wire on this side to keep the ankle joint stable, because it was tending to subluxate on this side. And we put a fixator to sort of protect the fixation. This you can see is an X-ray about 6 weeks after which it was removed. And he went on to do reasonably well. Unfortunately, because of the pandemic, we've not been able to get him back for a follow-up recently. Okay, now there are various complications. We mentioned AVN. Malunions are not uncommon. If you don't reduce it adequately, you're going to get malunions. Non-unions are relatively uncommon, but can occur if you haven't been able to reduce and fix it. And secondary osteoarthritis is not uncommon. And so if you look at some of the reports and the results in the literature, you can see that a lot of them have some problems post-op. So a certain amount of osteonecrosis, arthritis, almost 25% ankle, 53% subtalar arthritis in this series. So I mentioned the Hawkins sign. You will see about 6 to 8 weeks post-injury. And this lucency implies revascularization. Sorry. So that's a good sign. Okay, MRI, as I mentioned earlier, sensitive to detect AVN, but the implants may cause a problem. Okay. Now, what is important is, unlike or like other areas, AVN is not always associated. So, if there's collapse, yes, the result will be bad. But you can see about 1/3 of them collapse. More than 1/3 of them don't collapse, and close to 63% collapse. Okay. So if you get collapse, then you have a problem and will lead to secondary osteoarthritis. And AVN and collapse, as long as the subtalar joint is okay, will lead to problems with the ankle joint, and you may need something like a Blair type of fusion for that. Okay. Now, if there's no collapse, what we tend to do is to either treat them in a PTB cast or a PTB orthosis, which reduces the weight bearing through the ankle joint. So you're transferring the weight bearing through the patellar tendon, and it seems to help. We don't have strong evidence, but it seems to help. But once you have collapse, it's usually the ankle joint that is involved, and you would have to do a arthrodesis. Malunions, again, varus is the one that you have to watch out for. Most common, especially if you compress the neck on the medial side. And it's interesting that even 3 degrees of malunion will lead to decreased subtalar range of motion. And if you have a step off of more than 2 millimeters, you'll have altered subtalar contact forces leading to osteoarthritis. Okay, so if you have malunion, there's more pain, less satisfaction, less ankle motion, and worse functional outcomes. And you have to do things like osteotomies, sometimes of the talus, sometimes of the midfoot, sometimes of the calcaneum. You may have to combine it with tendo-Achilles lengthening so that they have good function. So this is an interesting case. This was an 11-year-old boy who presented to us about 2.5 to 3 months after the injury, and it had kind of malunited with this big bump here, which was impinging. So what we did was we went in, went through the fracture, reduced it, and sort of made sure that, so that was the CT scan showing the bump very clearly. And so what we did was we reduced it, we fixed it with these screws, and we also put a ankle distractor. So with the Ilizarov, we distracted the ankle as a form of arthrodiastasis. This is when this was taken out at about 6 weeks, and he went on to do quite well with a reasonable function. And you can see how now he's got a reasonable ankle joint, is able to dorsiflex, not full dorsiflexion, but at least much more than he had before the surgery. Okay, now arthritis, as I mentioned, of the subtalar joint, you would need to do a subtalar fusion. And if you have a pantalar arthritis that on both sides, then you might end up having to fuse both the ankle and the subtalar joint, which is something that you want to avoid using. Just a word about this extruded talus that I think every now and then, we haven't actually had one coming to us early enough to try and put back. There are a few reports in the literature of actually putting back this talus and getting reasonably good results. We've had 1 or 2 which have come to us too late with infection. So there you end up excising the talus. Some of these patients with talectomy do reasonably well. Others complain and end up needing a fusion. Okay, so I think it's important that we get good reduction if you're doing open reduction. Today, I think you would prefer dual approaches in most of these fractures. Avoid the varus. So if you just go through the medial side, this is a problem. Use combination of plates and screws. Remember, osteonecrosis does not always result in a poor result, but try to keep the soft tissue stripping to a minimum so that you do not cause the necrosis with your surgery. Part of it happens at the time of the injury, which you cannot avoid. And remember, arthritis after talus fractures is very common. Not all of them are troublesome, but if they are troublesome, you need to do it. And the best way to prevent it is to get a good reduction and fixation. Thank you very much for your patient hearing.
Thank you, sir. So I think we should have questions from the DNBs now. So a few questions what we have in previous year examination about the talar fracture is, one is about the classification of fracture of talus. So in that case, sir, it is talar neck fracture or talar body fracture also we have to write.
Okay, so there you first classify them into the various parts, okay? Neck, body, facets, processes, okay? And then the neck fractures, you give the Hawkins. Hawkins is basically for the neck fractures. There's also an AO classification. I think it comes as 81. The bone number given for talus is 81. And that has, it is kind of combines the Hawkins classification, but has a modification for comminution. Okay, so it has a special, so in the classification, you would also have a separate section for comminuted as well as non-comminuted fractures. But that's a little more complicated. So I think the Hawkins is one that most people use today.
And so you told that what we are using nowadays is Hawkins with some modification with, I think type 4 is addition of that. Only
Type
3
4
types.
it's still Hawkins type 4, but it was not given in the original Hawkins classification when he wrote his paper in 70. This was added on by Canale. Okay, so where the talonavicular joint is also subluxed. Okay.
And they have asked Hawkins signs, sir. You have explained that one. One question.
Yeah, so that is the sign of revascularization.
Okay. One question asked from Gautam is in follow-up patient after fixation, when to suspect AVN and at which time we think for intervention?
Okay, so I think you don't intervene immediately. Okay, so AVN, what you see radiologically would be increased density in the body area. Okay, and that can come sometime, usually probably more than 2-3 months after the thing. Okay, so we don't weight bear them usually for almost 3 months. Okay, this is one area where you don't weight bear very soon. Okay, you start early range of motion, but you don't weight bear them fully till at least 3 months. Okay, usually if you get any collapse, it will be after that. Now, if you see signs of AVN, then you delay weight bearing with something like a PTB cast orthosis. Okay, and so that you try to prevent the collapse as much as possible. Okay, today we add bisphosphonates. There's really not much evidence, but based on what it does with the neck, we add it to see, hopefully prevent the collapse. Okay, it doesn't help the vascularity, but it may prevent the collapse.
So another question asked by Gautam is about absence of Hawkins sign always lead to bad prognosis. Is it true?
No, I think if you don't have AVN, then the Hawkins sign is not of any, because it means that the body has lost its vascularity and it's getting revascularized. If it's not lost its vascularity, then you don't need the Hawkins sign.
So one problem what we used to face in the emergency to diagnose type 1 fracture, because in the neck, sometimes a faint line is seen. So what precaution we should take to avoid missing the diagnosis of type 1?
Okay, so I think first is to get proper good quality X-rays, like I said. Okay, a lot of things are missed because the quality of X-rays are not good, or like you keep seeing, unfortunately, even today's X-ray done with the slab on, etc. And if you have a thin fracture line there, you will miss it. Okay, then if you strongly suspect a fracture, get a CT scan done. Okay, so high index of suspicion, appropriate investigations, then you should not miss it. And the other thing is, in multiple injured patients, you need to do a secondary survey and check, because there your initial concentration will be on the pelvic injury, femur fracture, and if it's an undisplaced fracture, you will miss it. But when you do your secondary survey, you should not miss it. Okay.
So in case of open fracture, what is your approach?
So I think open fractures in the talus are close to a surgical emergency. Okay, so you need to get it back as soon as possible. I mean, when it also depends on, so at least the debridement should be done as soon as possible. Okay, whether you do the open reduction so if the patient comes in the middle of the night, you need to do a wound cleaning and any necrotic skin, all that, and try to get the thing reduced immediately if it's dislocated. Okay, now if it's not dislocated, then today for open fractures, we don't necessarily operate in the middle of the night if it's not contaminated or there is no vascular problem. So then you will wash it out, put them on antibiotics, tetanus medication, and then operate as soon as you have the proper setup to operate on them, because these are not things to be done by inexperienced people. But the debridement.
Yes, sir. In surgical emergency, sir, there is one open fracture and another thing you mentioned about the dislocation.
Yeah.
It is.
So you need to reduce the dislocation urgently, yeah? Even closed dislocations, because they might end up in skin problems, okay, because of the pressure on the skin. Okay. And then they end up with problems when you operate on them.
So there are many implants which is described in few papers, like some mini fragment, plate, or screws. So what is how to decide which implant is suitable for particular type of fracture?
So you have to look at the fracture, because you have plates in different shapes. There are plates specifically for Talus fractures available today with 2.4, 2.7 millimeter screws. Okay, so we use those. You can put them on the lateral side or on the medial side, wherever in the non-articular areas. Okay, screws you can put even in articular areas because you can countersink them. Plates you have to put in non-articular. Okay.
So like when we are using the plate, like in type 1 Hawkins, screws in Hawkins talonic fracture. So what is the usual direction of the screw, sir? And how many screw for a simple fracture? Like when it is...
Okay, now if it's a completely uncomminuted fracture, then you have two choices. One is a percutaneous posterior to anterior screw, and the other is anterior to posterior screw. Now, if you want the exact direction perpendicular to the fracture, anteriorly, that would mean starting from the talonavicular joint or the head of the talus. Here we usually start a little medially, okay, in the extra-articular portion. But in an undisplaced fracture, if you put two screws that way, it's enough. Okay, so that's one way of doing, or you come from posterolateral. In comminuted fractures, it's important to get the lateral side reduced first, because if you compress on the medial side, you will end up with causing varus at the neck. Okay, so that's the lesson that's been learned. So either use screws without compression, that means fully threaded screws, wires, etc., or you go to the lateral side, either put a screw on the lateral side or a small plate on the lateral side, and then do your medial screw fixation.
So in one journal, they have mentioned the classification on the basis of mechanism of injury. They have written it as failed in tension and failed in compression. So what is the difference between these two, sir? For talus fracture. Sir, for talus fracture, actually...
Yeah, you tell me, no? What does it mean? Okay, if it goes into varus, what does it mean? You have
varus means the medial
side and a
tensor side.
So on the medial side, it's a compression failure. Huh? Now, depending on the mechanism, it would vary. Huh? So it's like when you have a fibula in ankle fracture. Okay, when you have a varus, you call it a tension side failure of the fibula. If it goes into valgus, you call it a compressive failure of it. So it depends on which side you're looking at.
So usually what we used to find, sir, is medial comminution. So exactly. That is failure in compression.
Yeah, that is the compression side of most of these injuries because they go into varus. Okay.
And so when you are using a plate, sir, where to put the plate? Is it easier on medial side or on the lateral side?
You can put it so lateral or medial depending on the fracture. Yeah. Okay, so it would depend on what is the. So I think you have to study the geometry of the fracture and then decide on that. Huh? So there's a place in the medial side, extra-articular, where you can put it. So we usually put a plate on the lateral side more often than on the medial side, but sometimes we have had to put it on the medial side. Okay, so you have that area along the neck, which is extra-articular, before you come to the body. Okay.
So there are process fracture like lateral process and posterior process fracture also, sir. That is quite common. I have seen the evidences 18 to 20% they have written. So in those cases, sir, when to excise or to opt for a conservative treatment and when to go for surgical treatment, sir?
So I think if it's a small fragment which is not creating a major joint problem. So posterior facet right at the ostrigonum, etc. What do you call it? Fracture right at the tip of the posterior process, that you don't. But if it's a significant part of the posterior process involving the subtalar joint, then you need to fix it. So there you would go from the posterior side, posterolateral side. Okay, so we've done one or two. Unfortunately, I couldn't get the x-rays out for that, but we've done one or two fixations of the posterior process. We've done some of the, so like body and neck and parts of those area of the sustentaculum, we've had cases where there. Those need, so you need to study your CT, figure out which part, especially if the articular part is significantly involved, then it's better to fix them. A lot of them you can treat conservatively if it's just the tip of the posterior part.
So one confusion which usually comes in my mind is that about the sinus tarsi approach and anterolateral approach of Talus. Is it both is similar, sir, or some difference?
Well, they're similar, but it depends. So if you're going directly in the line of the sinus tarsi, it's called a sinus tarsi approach. If you go a little more onto the sort of along the anterior part of the fibula, more on that is your anterolateral approach.
So,
tarsi approach typically you use for some subtalar arthrodesis and for maybe even for a minimally invasive or the less invasive fixations of the calcaneum, where you use a sinus tarsi approach. Okay, so that is actually between the talus and the calcaneum rather than right at the neck of the talus. So here you tend to use an anterolateral approach, but you can approach the sinus tarsi with that approach.
And about the talar body fixation, sir, what usually is the approach? Is it same or different?
Yeah, so that's where if you can't get at it, then you need to do a medial malleolar or even sometimes a lateral malleolar osteotomy. Yeah. So you approach it similarly, but you may have to add an osteotomy to get approach to the posterior part of the body to fix it. You have to put screws across.
And what is the ideal method of doing osteotomy, sir? Because in few papers there are so many failures of osteotomy, like, and there are so many methods they have, like Sharan, step cut, and all. They have described or oblique osteotomy. So which one is?
So again, it's like olecranon osteotomy. Yeah? I mean, I'm still happy with just doing a transverse osteotomy, okay? Because I know I can fix it. But if you feel you have some issues with it, do a chevron. Okay.
And so one thing about the talectomy, when to decide on that? Like,
so I think that would be more for either something like an extruded talus which has come late with infection, or a completely dislocated talar body, again where there's infection. Huh? Okay, so talectomy used to be the surgery of choice in talar fractures at one time, okay, before World War I. That was what was advocated for displaced talar fractures, was talectomy, but not today. Huh?
and so in case of avian of talus after the fixation or before that one, so how to manage those cases?
Well, I think we went through that. Huh? As long as there's no collapse, you try and avoid weight bearing. Use PTB casts or orthosis. I mentioned we use bisphosphonates. It's more empirical, but based on the fact that you don't want it to collapse. Okay. And then observe and see what happens. If it starts collapsing, and here the collapse is usually in the ankle joint, they may need an ankle fusion. If it is also a malunion involving the subtalar joint, then you might get subtalar arthrodesis when you need to do a subtalar fusion. And if you've got problems both sides, then you might end up with a pantalar fusion or a hindfoot fusion.
So we have heard a little bit about the total ankle arthroplasty. So is there any role or? in the future?
So ankle arthroplasty for post-traumatic arthrosis is still not a very well accepted method of treating them because the failures are quite high. It's more, but I think definitely there is some recent advances in that direction, but you wouldn't do it for a talar fracture straight away. Huh? You may do it for a malunion or something like that involving the ankle joint or arthrosis involving the ankle joint. There won't be a primary treatment for a fracture by any chance.
In case of poor bone quality or in the diabetic patient, is your treatment varies or is it?
So these are the ones where you might supplement with external fixation to protect your fixation. Okay. Diabetic, you have to be careful of the skin. Okay. Issues of skin problems and infection or something that you have to keep in mind. But if you're worried about quality of fixation, one option is to put a spanning fixator. We do that once in a while.
So I think we have asked most of the questions on this topic, sir.
Sure.
Yeah.
Okay, thank you. Until next week. Okay, bye.
Thank you, sir.
Okay, thank you. Bye.